Welcome friends to the new episode of our YouTube series How Do Expert Manages It. Since the videos are posted on YouTube, one can watch and listen it as and when time permits them. Our today's subject is safety in hysteroscopy. It will be presented by our expert faculty, Dr.Sejal NAIK. Dr. Sejal NAIK is a gold medalist in MS examination. She is a consultant obstetric gynecologist, endoscopic surgeon and infertility specialist at Bailey and Love Women's Care Hospital, Surat. She is first gynecologist to perform single incision laparoscopic hysterectomy in Gujarat. She is honored with Foxy Young Achiever Award in 2018. At present, she is a managing committee member of IAG, past honorary secretary of Surat Obstetrics and Gynec Society 2018-19. She has published numbers of articles and chapters in various index journals and medical books. She is a regular faculty at most national and international conferences and also a regular faculty at live surgery workshops at many conferences.
Begin with safety in hysteroscopy. So as the golden rules described by Hama in 1993, the proper patient selection for hysteroscopy, the surgeon's experience, that is the most important thing, good instrumentation, clear visualization with continuous uterine distension, and concurrent use of laparoscopy or ultrasound as and when needed. If we follow those rules, there are very less chances of encountering the difficulties. Though the complications rates are very less, approximately 2% of the operative hysteroscopy, the rate of major complications like perforation, hemorrhage, fluid overload, urogenital injuries are extremely less, though the 50% of the perforation occurs while entering. So the majority difficulty we encounter during the entry. How good, it has been said that good beginning is half done, and it's very true in hysteroscopy. The complication rates being very low, though the 30 to 40% only gynecologists perform the operative procedure. Why? Because they lack in confidence, they lack in training, they have fear in entering the unknown areas, because as in postgraduate curriculum, hysteroscopy is still not included as a routine. We know that the cave we fear to enter holds the treasure we seek. So let us discuss today the main complications related to entry, that is either mechanical complications like completely failed entry, cervical lacerations, trauma, or false presage and perforation of cervix or uterine cavity due to excessive force, maybe in wrong direction or mistaking the anatomical landmarks. The technique-related complications are maybe embolism and vasovagal shock. So to prevent complication, the rule of thumb is to remember the contraindication of hysteroscopy. Those with acute pelvic infection, pregnancies or genital malignancies, those who are the poor surgical candidate with multi-organ problems, and of course, untrained surgeon and his staff. One has to have a very great suspicion of those and selection of those patients who are very high risk of having the difficult entries. Those are with the cervical stenosis, with nulliparous patients or postmenopausal patients, those who had prior GnRH therapy, the uterus in which there is very acutely anteverted or retroverted, especially in severe endometriosis cases, the patient with congenital uterine anomalies with septated uterus or the diaphragmatic uterus, etc. The patients we have expected the intrauterine adhesions, Herman syndrome, where the anatomy is completely distorted and we lost the anatomical landmarks. Sometimes the submucous myoma lying in lower segment or in the cervical canal indenting the cavity and makes a difficulty in negotiation. The patient with previous cervical surgeries like bone biopsy, cryosurgery, etc. And of course, the light plane of anesthesia leads to more complications. Pre-op ultrasound by surgeon himself is most important here. We can decide the plan of negotiation of your hysteroscope. We can find out the cervical length and the acute anteversion or retroversion of the uterus. And if we can perform the 3D or 4D ultrasound, that can give us a virtual hysteroscopy and can map our plan intraoperatively. The role of cervical ripening agents is controversial here. It's like routine use may not be needed, but yes, it can prevent the cervical lacerations and reduce the time of cervical dilatation, reduce the operative time, and reduce the trauma related to cervical dilatations. So maybe in high-risk patients or those patients when we suspect to have difficult entry, can be used with 200 microgram of vaginal misoprostol, but it has limitations of use in postmenopausal women, and data doesn't support in such a female that it's helpful. And more commonly we found there is a uterine cramping, pain, or spotting bleeding, so which is discomfort to the patient, but it obviously not significant, the complication that it prevents. Vaginal estradiol preoperatively 2 weeks prior treatment along with misoprostol can be tried for postmenopausal lady. So here we see the video of difficult entry. The main rules to follow during each hysteroscopy is the proper positioning of the patient that allows the movement of your hysteroscopic assembly, do the white balance, remove all air from air tubings and also the hysteroscopic assembly, keep the irrigation on, and then start negotiating. Know your optics. If you are using the 30-degree telescope and your cable, this notch indicates the position of the cable. So your cable, if it is at the 6 o'clock position, you are visualizing more of the anterior wall. So your lumen should be eccentric towards the 6 o'clock position, should not be at the center. Otherwise, you are looking the lumen at the center and negotiating towards the anteriorly and may perforate or may injure because the false passage. So keep the lumen, position the lumen towards your notch or this position of the cable in 30-degree telescope. Another rule is never force. So whenever you are doubt and you are unable to visualize it properly, withdraw a bit. 2 steps ahead and 1 step backwards is the rule of hysteroscopy. Allow the distension fluid to distend the canal and then negotiate under vision. So this is the beautiful case of difficult negotiation due to multiple cervical polyps and acutely anteverted uterus. This is another case in which we did the vaginoscopy, and then you see the visualization of the cervical os, then introducing the assembly, keeping the lumen towards eccentric towards the notch, and then entering into the cervical canal. We thought we entered into the cavity. That is a huge area, and we tried to find out the tubal opening, the osteas, but it was not visible at that time. So we found it some fishy. We withdraw the telescope. We find out we confirm the cervical canal. We are not in false passage. So then we again introduce it further under vision and rotate the cable all around to have the panoramic view, and we could see the good cavity inside. So it was the large ballooning of the lower segment that was because of the previous cesarean scar. There is no such a board on any patient that wrong way and go back, no such a warning sign. So one has to understand the myometer fibers, that crisscross patterns that is lost when we detect how we can detect the injuries, and if we have perforated, then it is the loss of distension sometimes and abnormal uterine bleeding. So this is the case of severe endometriosis where uterus is acutely retroverted, and we were having doubt of having difficulties in negotiation. So we were very careful. Though when we introduced, we had to use unnecessarily extra force, and that came into our mind that something was wrong. There was a not proper distension of the cavity, and we couldn't see proper planes, and then there was no endometrial tissue. So we withdraw the telescope further. It was looking like a cervical canal, but lumen was not clearly visible, and we keep on withdrawing, and we keep on trying for searching rather than pushing ahead, and we could see there was some band of adhesion or some opening on extremely left side towards the 11 o'clock position, which was missed, and actually then we try to focus that opening at the eccentric position, and we try to negotiate it through that opening, and it was actually the proper cervical canal and uterine cavity, the correct path. After performing any diagnostic hysteroscopic procedure, while you withdraw your telescope, we need to resuspect our false passage, and we need to reconfirm any further injuries by laparoscopy or laparotomy SOS to confirm the bleeding or an injury to any adjacent viscera. So while removing, you can see there was a band-like structure. It was a completely false passage, and we were about to do the perforation, but luckily we stopped at the crucial moment. So how we can tackle these difficulties preoperatively? As we all know, can use the pre-cervical ripening. Intraoperatively, we can use the narrow caliber of hysteroscope. We can pull the cervix and align the uterocervical angle. One can use the vasopressin or lignocaine combination of solution. And if required, ultrasound guided entry or laparoscopic guided entry can be done. So suppose we by mistake do the perforation or we do the false passage. So majority of the time, if there is no bleeding, we can monitor them conservatively, can give antibiotics and just monitoring. In case of severe bleeding, one may need a laparoscopy or laparotomic suturing. So pearls here are the optimum training of a surgeon is the must, awareness of the risk factors, identifying these risk patients, those who may have difficulty, and pre-op ultrasound is important to reduce the complications, and plan procedure with all precautions. A word on vasovagal shock is very unpredictable here, and especially occurs during the cervical dilatation. The common signs are vomiting, dizziness, sweating, or blackouts, and how we manage by giving a Thunderbird positions, withdrawing the procedure, and replacement with fluid and atropine. So air embolism here is potentially very lethal complication, though very rare, and most common causes are when carbon dioxide is being used in operative procedures, especially with the NAIK laser. And second most common cause of air embolism is forget to remove the air from tubings and the hysteroscopic assembly while introducing. Even the vagina is very vascular, cervix and uterine cavity are very vascular. They absorb the air approximately 40 centimeter cube and can cause a bolus into the, and that blocks the cardiac chambers or the great vessels and cause the air embolism. Inoperative hysteroscopy during the procedure also it can happen when the irrigation fluids is over and nobody watches and you are under pressure using the this electronic pressure pumps, and that pushes the gush of air and causes the embolism. The most important thing to prevent is the vigilance of your anesthetist and your team on finding out the very first important signs, that sudden drop in CO2, bradycardia, arrhythmia, and typical precordial will murmur, but usually it's a fatal condition by the time you detect and treat. It is too late. So prevention is the most important, and whenever you feel there is an air embolism, you can administer 100% of oxygen. We stop the procedure, cardiac massage, and precordial thumb to dislodge the carbon dioxide. And how you prevent? By avoiding the steep tenable position and keeping covered the cervix while withdrawing the hysteroscopic assembly, and de-aerate the equipment prior to surgery using the low pressure CO2, and be highly suspicious whenever there is any signs appears. So surgeon skills remains the best safety measure in operative hysteroscopy. So I wish you all to learn and be expert in it, and do not enter until authorized. Thank you. Thank you so much.
Thank you very much, Dr. Sejal, for a very interesting and informative talk with slide presentation on this very good subject. Friends, please like this video and share the link to your friends, your colleagues and students. Please subscribe this channel to watch such videos in future. Thank you very much.